Welcome once again to the part 4 of GMDC internal medicine tutorials. So let's begin. A middle-aged man said to have been coughing over the past 2 months was referred to your clinic. Okay, coughing for 2 good months was referred to the clinic. He is a known alcoholic, noted to have a significant weight loss. Guys, chronic cough, okay, and a significant weight loss. This is your clue to your diagnosis. Of course, the person is what? A known alcoholic. Sorry for that. All right. So what will you be talking about? You are definitely looking at a problem with, for chronic cough, you are looking at a problem with the lungs. Chronic cough has to do with the lungs, So whatever it is, we will be concentrating more on the lungs, for which the person is having what? A significant weight loss. All right. So let's go to the questions. What would your direct questioning entail? So you want to find out, like I said, we are looking at a problem with the lungs. So what sort of questions are you going to ask this person? 1, is there fever? Is there fever? Night sweat. Has the person come into contact with any chronically ill patient? What is the nature and the character of the cough? Is there blood in the cough? That is called hemoptysis. Do we have chest pain? You are asking all of these because you want to, or you are thinking of a problem with what? Pulmonary tuberculosis, isn't it? Tuberculosis. So you want to know the fever, the night sweat, the nature of the cough, the hemoptysis is present or not, chest pain, and contact with a chronically ill patient. You want to know all of these things so you can ascertain or you can confirm your diagnosis. Okay, so what investigation will you recommend? What investigation are you going to recommend? So 1, you're going to do what? Your full blood count, your ESR, you're going to do your sputum AFB, sputum acid fast bacillus. Acid fast bacillus is for diagnosing tuberculosis. And of course, you have to do your culture and sensitivity. You can also do sputum gene expert. Sputum gene expert. You can do chest x-ray, then retro screening or retro screen. So again, full blood count, ESR, sputum for AFB and culture and sensitivity, sputum for gene expert, chest x-ray, retro screening. So these will be the investigation you would like to recommend. All right. Likely diagnosis, of course, pulmonary tuberculosis. All right. What drug combination is this patient likely to be put on if your diagnosis is confirmed, and then list the side effect of any of the 2? So drug combination. So you ask yourself, what is the drugs for treating tuberculosis? And you know the mnemonic RIPE. R-I-P-E, RIPE. Know this RIPE. And RIPE simply means what? Rifampicin, isoniazid, the P stands for parazinamide, then the E, etambutol. Again, rifampicin, isoniazid, parazinamide, etambutol. So now let's look at the side effects of any of them. So with rifampicin, we can have hemorrhagic cystitis. You can have hemorrhagic cystitis. With isoniazid, we can have peripheral neuropathy. With parazinamide, we can have severe hepatotoxicity. Then with etambutol, we can have optic neuritis. optic neuritis. Optic neuritis. So again, rifampicin, we have hemorrhagic cystitis, isoniazid, peripheral neuropathy, ethambutol, optic neuritis, parazinamide, severe hepatotoxicity. Severe hepatotoxicity. So these will be your drugs combinations. All right. Ripe. Don't forget that. Ripe. A 27-year-old female presents to your consulting room with an anterior neck swelling, which moves on swallowing. She also has associated palpitation. Her BP on presentation is high. She had recorded an equally high BP 2 days ago when she was seen in another clinic. So that means hypertension has been established in this patient, isn't it? Now there's what? Neck swelling, anterior neck swelling. And we are seeing some signs and symptoms of what? Hyperthyroidism. Hyperthyroidism. Because in hyperthyroidism, we have what? Palpitations. We have increase in what? In BP. That's what? Hyperthyroidism. All right. So now let's look at the question that they might be asking us. Okay. And again, when you see a problem with the anterior neck swelling, definitely you are thinking of all the differentials you could be looking out for, isn't it? This definitely goiter, isn't it? But we have different types of what? Goiter. And that will be an assignment for you to do. So go and look out for the different types of what? Goiter, the non-toxic, and then the toxic type of what? Goiter. Look out for all of these things. Okay. Look out for all of these things. All right. So now look at the questions. What is your diagnosis? So over here, we are looking at, we can say hypertension secondary to thyrotoxicosis. Hypertension secondary to thyrotoxicosis. Or we can say we have what? Thyrotoxicosis and we have hypertension. Okay. But I believe the hypertension is as a result of the too much of thyroxine, or it's as a result of the thyrotoxicosis. So you can write in one of them. So you can write thyrotoxicosis or hypertension, or hypertension secondary to thyrotoxicosis. All right. What other symptoms will you inquire about? What other symptoms? Of course, people with too much thyroxine, you might want to check for weight loss, tremors, diarrhea, heat intolerance, excessive sweating, amenorrhea. Again, weight loss, tremors, diarrhea, heat intolerance, excessive sweating, and amenorrhea. Amenorrhea, if the person is a woman, of course, because guys don't have amenorrhea. All right. So these will be what other symptoms we will be looking at for. In your examination of the patient, what signs will you be looking out for? What signs will you be looking at? So these are what the symptoms. Now, what signs are we going to be looking out for? So with the eye, okay, with respect to the eye, you know it already. We can think of what? Late retraction, late lag or late lagging. That's the eyelid. So late lagging, late retraction, exophthalmos. That's bulging of the eye. We can talk about ophthalmoplegia. So these could be what? The signs we can see with the eye. Now let's talk about the hand. It can be what? Tremors, involuntary shaking of the hands. We can have sweaty palms. We can have thyroid agropathy. So as an assignment, check out for the meaning of thyroid agropathy. All right. Then you can do CSV, cardiovascular system. Okay, the cardiovascular system. So on the cardiovascular system, we can be looking at for tachycardia, arterial fibrillation, high blood pressure. Then we have the thyrotoxic heart disease, whereby there's what? There's a displaced apex, suggestive of dilated cardiomyopathy. So thyrotoxic heart disease, there can be what? A displaced apex, which is suggestive of dilated cardiomyopathy. Okay. Then we can look at the legs. The legs. What can we see on the legs? We can see pretibial myxedema. Pretibial myxedema. Then we can see hyperreflexia. Hyperreflexia. Again, if you group this in like this, it is easy to get a lot of points. But in exams, you can just write them. Okay. But then again, let me just harness again. With the eye, we can have what? Late lag, late retraction, exophthalmos, ophthalmoplegia. With the hand, thyroid agropathy, sweaty palms, tremors. With the cardiovascular system, tachycardia, AFib, high BP, displaced apex beat, suggestive of dilated cardiomyopathy. And then with the legs, we can talk about the pretibial myxedema and hyperreflexia. Of course, you can add as many as you want to add to, as you see. All right. But for now, we'll go with these things. All right. What will be your plan for investigation? What would your plan of investigation be? Plan of investigation. So one, we can talk about the diagnostic plan, because you're thinking of what, problem with the thyroid. So you can do what? The thyroid function test. Thyroid function test. Then you can do an X-ray of the neck. This can be anterior posterior or lateral view. Anterior posterior or lateral view. So definitely X-ray of the neck. You can do an ultrasound of the neck. Ultrasound of the neck. Ultrasound of the neck. They can do thyroid antibodies. Thyroid antibodies. Thyroid antibodies. Then radioiodide scanning. Because iodine is needed for thyroid production. So you might want to look at what? Radioiodine scanning. Radioiodine scanning. So these can help us. These are diagnostic. Now let's talk about the supportive investigation you can do. Supportive, you can talk about the full blood count, the ECG, the BU-creatinine, the urinary, the lipid profile. Lipid profile. So these are all what? Supportive. Then the first one I mentioned are all what? Diagnostic. So in an exams, look at the space available and write as many as you can. Write as many as you can. Okay. A 54-year-old smoker. 54-year-old smoker presents to the ER with acute onset of shortness of breath. Okay. He is said to have been involved in road traffic accident, sustaining minor injuries to the right lower limb, for which he had been immobilized. BP is 85-60. This is quite low. Okay. So this person is a smoker and is having what? RTA, and of course, there's right lower limb injury. So definitely, you could be looking out for a problem with what? With the deep vein, isn't it? With the deep vein in the legs. Deep vein in the legs. Again, this person is or cannot move or is immobilized. Great. So basically, very easy for us to, wrap our minds over. And again, there is what? Shock, isn't it? Shock is coming in. So what are the risk factors? Risk factors for this. What are the risk factors? So risk factors for whatever we are looking at for, basically the deep vein problem for which he was what? Immobilized, the deep vein thrombosis, maybe. All right. So what are the risk factors? Risk factors include smoking. We can have trauma secondary to RTA. Then we can have what? Immobilization. So if somebody doesn't move, or usually bedridden patient, they end up developing DVT or thromboembolism. Pulmonary embolism, sorry. Thromboembolism. So the same thing. Pulmonary embolism, they tend to what? Develop these sort of what? Things. So again, smoking, trauma, immobilization. These are risk factors for pulmonary what? Embolism. Pulmonary what? Embolism. All right. Now let's look at it. What is your likely diagnosis? Definitely, our likely diagnosis is what? Is pulmonary embolism or pulmonary thromboembolism. Pulmonary embolism. Secondary to DVT of the right leg. Secondary to DVT of the right. Of course, we want to query it. We're not sure, but we want to query it because there's also shortness of breath. Because of shortness of breath, it means that there's problem with definitely with respiration. And the only way there can be a problem with that is because of what? There's a blockage or something has gone to block or lodge in there to prevent air from flowing. So that's why we talk about it as what? Pulmonary embolism. Secondary to possible or querying DVT. DVT of the right leg. Of the right leg. All right. What signs would you look out for? What signs? So definitely, we talk about it. Tachycardia, tachypnea, low SpO2, crepitations. Then you can have a unilateral leg swelling. Unilateral leg swelling with differential with calf tenderness. So again, unilateral leg swelling with differential with calf tenderness, tachycardia, tachypnea, low SpO2, crepitations. So all of these, and of course, if you have low SpO2, you are likely to have what? Cyanosis as well. So all of these are all signs that we can see in this patient, or we're likely to see in this patient. All right. What investigation will you do? Of course, you are thinking for DVT. So you do what? Your D-dimer. Then you might want to do what? A Doppler ultrasound of the right leg or the affected limb. And again, you can add ECG to know the electrical beats of the heart. You can do a CT pulmonary angiogram. CT pulmonary angiogram. And of course, your favorite full blood count. You can also do the full blood count. Again, you can do ECG, D-dimer, CT pulmonary angiogram, Doppler ultrasound of the right leg, full blood count. Some even add INR. International normalization, something. INR. All right. So these are the investigations you are going to what? Request. All right. Okay, let me just add this one. Okay, I didn't add it. So let me just add this one. How are you going to treat this patient? How are you going to treat this patient? So again, this is an emergency case. So definitely you will have to admit the person, do your, you assess and stabilize your ABC. Then you give intranasal oxygen. Then you give anticoagulant with heparin or warfarin. Either heparin or warfarin. Then you can identify and treat other risk factors that may be present. Identify and treat other risk factors that may be present. So basically, that would be all for the treatment. Again, admit, assess and stabilize your ABC, give oxygen, anticoagulant, identify and treat other risk factors. All right. We have a 45-year-old woman with insomnia and loss of interest in her hobbies. Oh, there's insomnia, can't sleep, loss of interest. Over the last 3 months, had stopped attending choir rehearsals over the same period. Her niece noticed she has lost weight and barely eats. She is said to have lost her husband 4 months ago. Oh, so that means that the demise of the husband is, leading to some of these things, isn't it? And that's telling me that this person is depressed. Imagine you lose your loved one. Just relate with it. Relate. All right. Because I know one way or the other, you have lost a loved one before. If you don't take care, you can be what? Depressed. So What are we looking at over here? Definitely, we are looking at a clinical depression. Clinical depression. She has lost interest in anything. She can't sleep. She's trying to avoid her. She's trying to avoid or isolating herself. Okay, she's isolating herself. She doesn't want to mingle with people anymore. She doesn't want to socialize anymore. That is a sign of depression. They want to be on themselves, by themselves. What other symptoms would you ask about? What other symptoms? Well, you can ask about low mood, feeling hopeless, guilt feeling, then trouble with concentration, memory, or making decisions. If they have trouble concentrating or, problems with memory or making decisions, appetite changes, then irritability, then one of the most important one, suicidal thoughts. Those who are depressed, they think about suicide a lot. Let me just die and everything will end. Who knows? That's what I've been lied to, that if you die, everything ends. Anyway, it's only God who knows what is behind the death. Anyway, so low mood, feeling hopeless, guilt feeling, trouble with concentration, memory, or making decisions, appetite changes, irritability, suicidal thought. These are other symptoms. Just mention 4 and you're okay. One important complication. Guy, suicide. Please, suicide. That is the one major complication of depression, suicide. What are the available management options? How are you going to manage these people? So either we manage them with medications. So we can give the selective serotonin reuptake inhibitors. We can give them sertraline, the fluoxetine, and so on and so forth. We can give them these drugs. Then we're going to give them what? ECT. ECT is also another treatment option, also known as electroconvulsive therapy. And this is a medical treatment most commonly used in patients with severe major depression or bipolar disorder that has not responded to other treatment. So that's when you use the ECT or the electroconvulsive therapy. And lastly, but not the least, we can think of psychotherapy. Psychologically, they need to be, cautioned, or they need to be, educated upon them. So psychotherapy, they need it. All right. So I watched a movie some few days ago, Shooter, I don't know, designated survivor. The president lost his wife and has to go through this kind of counseling. Okay, so they're trying to make sure that he's in his right senses. All right. So a 25-year-old woman was diagnosed with HIV 3 years ago. When she presented with a frequent diarrhea and a significant weight loss. Patient is non-compliant on medication. She is said to have had seizures 3 days ago and was managed at a polyclinic. Patient was rushed to your ER with a history of abnormal behavior. Temperature 37.9. Guys, they've told you about HIV. When you have HIV, you are susceptible to a lot of diseases, okay? Especially some types of diseases. They are like opportunistic infections. Let me put it that way. So for them, anytime the immune system is very low, they are very, very happy. And today we're going to look at these opportunistic, infections. So let's look at what the differentials. So the differentials simply talks about the opportunistic infection. So we can talk about the cerebral toxoplasmosis. We can talk about tuberculosis meningitis. We can talk about streptococcal meningitis. Not strep, creptococcal. That's like fungus, okay? Streptococcal meningitis. Then bacterial meningitis, bacterial meningitis. So these are some of the opportunistic infections, or let me just say differential diagnosis for our case over here. So cerebral toxoplasmosis, tuberculosis meningitis, cryptococcal meningitis, bacterial meningitis. So any two, and you are good to go. And again, all of these things can also lead to seizures. What signs would you look at for in your clinical examination? So over here, we are looking at what? The signs. Signs. And again, you want to look at what? Now, with all these things, you want to look at signs of what? Meningism. Signs of meningism. Because if you're thinking of meningitis, all those things, signs of meningism should come to your mind. And what are the signs of meningism? We talked about it, I think, in our first lecture, first lecture or so. So we talk about the neck stiffness, the Kerneck sign, the Brzezinski sign, the photophobia, the phonophobia, the intoxication syndrome. We talked about all of these. Again, the neck stiffness, Kerneck sign, Brzezinski sign, photophobia, phonophobia, intoxication syndrome. Please, if you have not watched the videos, do well to watch them. Okay, do well to watch them because everything is being built upon them. Everything is built upon them. All right. What investigation will you carry out to confirm your diagnosis? So again, this is brainstorming. So what are you going to do? Definitely lumbar puncture. One of the major things, lumbar puncture. Then you can do your CT scan of the head. Then you can do, because you're thinking of tuberculosis, you can do the sputum AFB, acid fast bacillus, culture sensitivity, or gene expert for the tuberculosis. You can do all of these things. You can do your chest x-ray, your full blood count. Then you can do your toxo antibodies or crypto antigen, or these are called immunology. So you do your immunology test. Immunology test. Into bracket, toxo antibodies or crypto antigen. Again, CT scan of the head, lumbar puncture, sputum for AFB, CS, and gene expert, chest x-ray, full blood count, immunology, toxo antibodies, crypto antigen. Basically, these are the investigations you will carry out. So depending on the space that you have in your exams, please write them. As many as you can remember, write them. But don't forget lumbar puncture. All right. Outline your management of one, just one, of your likely diagnosis. How are you going to manage any one of them? Any one of them. So first of all, you will want to what? Monitor and control the seizures. First of all, monitor and control the seizures. So now let's come to cerebral toxoplasmosis. In cerebral toxoplasmosis, you can give high dose of septrin. High dose of septrin. High dose of septrin. In tuberculosis meningitis, you can give the anticox. The anticox, you know them already. You can give anticox. The coccal meningitis, you can give fluconazole or amphotericin. Then for bacterial meningitis, you can give your antibiotics. Example, the ceftriaxone. Antibiotics or ceftriaxone. So these will be your management option. Please don't go and write all of them. Depending on one. So just take one of them that you know very well and you just manage it. Or you can remember very well. Just manage it. Just take one. So apart from monitoring and controlling your seizures, just pick any one of them. Whether cerebral toxoplasmosis, whether tuberculosis, whether crypto, whether bacterial meningitis. Just pick any one of them and answer. Don't write all of them. Pick one and answer. All right. So basically, that is it for that question. And again, that brings us to the end of another session with you guys on internal medicine. Feel free to ask your question, put your contributions there. Let's get interactive in the comment section. All right. So until then, see you again. Peace out.